I think this is very important because you will be evaluated. This is already ingrained and in our system, and it's not only the patient but also the professional that is involved. No disclosures. Well, I always say to young urologists and residents, qualifications will hire you, but behavior, depending on your behavior, you can get fired. And nowadays, with more administration in your life, administrators that do not understand some of the clinical issues and the stress and the burnout, they will tend to press you so much that you may have some of the behaviors that are not expected, but this is human nature. So let me give you a little bit of a history of how we started to write these papers for the white papers for the AUA. More than 10 years ago, the ABU, Dr. Jerry Jordan, and Dr. Tim Average honored me, inviting to be part of this endeavor and try to put a core curriculum. And we did this. How many of you, very honestly, have seen this patient safety core curriculum in the website? Oh, thank you so much. That means a lot. Probably you are the only few 7, 10 people, but it's in their ethics, and we try to really design. We were in the, first steps to try to give you a sense of what are the things that probably the specialty and the managers are expecting from you. And finally, after probably it took a year and a half, I think, we had 3 work groups working together to produce these white papers that are published now on the website. And John Stoffel, a great friend, he put a lot of effort, and they were responsible for the preoperative part of the patient safety, and really was very imaginative in terms of putting a really nice title, Optimizing Outcomes in Urologic Surgery, Preoperative Care for Patient Undergoing Urologic Surgery or Procedure, instead of just saying patient safety preoperative steps. So I thought it was very good. The second work group was very well chaired by Kristen Schalzer, and she did a very tough, and it was a great job. And the title was the intraoperative part, the optimization or optimizing outcomes in urologic surgery, intraoperative considerations. And this is the part that I'm gonna go a little bit more in detail since I participated, and also this will actually talk about behavior and things that you may, as a leader, take some advices and some good information to your practice. And the third group was chaired by Angie Smith, and the title was Optimizing Outcomes in Urologic Surgery, but it was more about the post-operative care. So the key parts of all these different steps or parts of the patient safety is the culture of shame and blame. Do not blame people about certain things. Try to get the root cause and analyze and try to solve it in a good way. The near misses are sometimes much more important to report than the bad outcomes. Just culture, the culture of just, is very important to be implemented in your institution. And if you don't have that, then you have to navigate and you have to gather more momentum and try to torque that forward to really get some people that can change the culture in your institution. That's much more challenging. And have the culture of patient staff safety, including you, the surgeons. Systems thinking is important to understand where this comes from, and I'll talk about that. And we are a high reliability industry, and that's sometimes I myself think that we are a high risk industry, and it is very tough to nowadays work in that kind of environment. There are human factors that will influence all these issues of patient safety. And this has been really studied a lot, but not in urology, not that much in medicine, a lot in psychology and in behavioral sciences used for the business marketing people. And there are several aspects that you have to understand to try to improve, optimize your actions and your work. People is the center and may be affected by environment, organizations, tasks, and the technology. And like we discussed in the first part of this talk, the first day was human performance. You are actually required to work very hard, but sometimes we think that we really underestimate our limitations, and the tendency is to burn out and not say no. We gotta learn how to say no. What are what impacts human performance? There are some external factors and internal factors. The external factors: noise, distractions, interruptions. You're operating and people come to you, or seeing a patient and 10 questions from different nurses are coming. Task design: sometimes your tasks are actually to do a meeting here, a meeting at the same time, but you forget that you have to walk about 10 or 15 minutes or drive. And environmental conditions, environments that will provide you some comfort and some ways of relaxing while you're stressed. Internal factors: fatigue, stress, anxiety, depression, and insomnia. They're all kind of intertwined, and you gotta be aware of those things, and you may get help. You have the right to get help, and don't be ashamed of that. The systems thinking actually was incorporated in our industry, and I think we tend to use the microscopic view and try to solve the problems, but you have to look more in a global way and how the landscape of healthcare system is now and where we're gonna go will progress. There are more MBAs and people that understand stats and numbers than actually physicians in leadership positions that instead of just counting the beans may think more globally in terms of your well-being and the well-being of the patients and their families and the people that even the janitor that takes care of the cleaning of the rooms and your institution and the buildings. So safety and quality, the more I study, I learned that this safety notion and quality came from studying from the aeronautics industry, studying the human factors. Well, there are a lot of checklists they have, and we are incorporating those checklists into our practice. And our group, we try to get a good review, and in a very clinically oriented way, we use the model of James Reason, who had the Swiss model checklist type of alert when something goes wrong. If you have a hole and you start with the wrong side of the surgery, and then you don't know the surgery and the name of the patient, all that goes through no checklist, and there's a hole in the cheese, that basically you tend to do something wrong at the end. But if the cheese is sliced and the holes do not connect from the beginning to the end, that means there are checklists and alerts that you can prevent a bad outcome. That's basically what it is. An example here is about allergy. I'm sorry you cannot see this, but you're going to see in your PDFs when you go home. You're going to receive an email about all the slides, all the talks. But it's basically about antibiotic usage, and this patient is allergic to penicillin. And if you don't have a checklist, you may miss that and end up having a bad allergic reaction and a bad outcome. So when we talk about preoperative care, what are the things that this white paper is basically giving the information? It's about the informed consent, the goals, and the expectations that the patient needs. But also, there are some social needs that you got to understand. If you have an 80-year-old patient that you had to have an operation, how that patient will recover at home. You can do a great surgery, everything goes well, but he doesn't have any help to eat or check his insulin, and he may have a very bad outcome, a lethal one. So it is important to have the social part of this, including your social service and family members, if they have. Also, this is very well studied, the frailty and risk calculators, depending on your physiology and functional and physiological reserve. It is important to do a very detailed preoperative evaluation, and that depends on each organization who does it, and including the anesthesiologist department, and having them calculating what we can prevent to have a bad outcome. So we know from the trauma literature, the medical MICU literature, intensive care unit literature, that there are some cognitive impairments and delirium. Those are, you can try to predict, but if the patients, they end up having those really bad experiences, they can have a bad outcome. For example, in our trauma center, there is a quiet time, which is the lunch time between 12 and 2 p.m., and another one after the sun goes down. So that during that time, the lights are dim, there's only the alert beeping and no visitors, and at that time, the patients can really rest. So those are the important things that we gotta do, and really understand the patient is a global world. It's not only the physical part of you cutting and stitching up and or putting together or taking something out of the body, but when you have an uncontrolled pain, these patients will suffer other consequences. So in the area of using really very carefully the narcotics, during the hospitalization, of course, you don't want to have patients that will depend on those painkillers when they go home. But it is important to understand that when they are not treated well, they cannot sleep well. They may develop depression, not only because they cannot sleep well, because it can be because of the nature of the disease, if it's a cancer operation or a quality of life operation, but there are a lot of things that you have to consider. And consider patients that had history of alcohol, they can go quickly to abstinence, and those are the important things that you have to consider as a global care. The intraoperative strategies, one thing that you really want to be consistent is doing the timeout, identifying the patient, trying to get to know very well the team that you are working with in that operating room, and understand when they should actually release the other scrub tech to take a break. Dvt prophylaxis, everybody know. I will not spend much time about this, but this is something that you should have in protocol as a quality safety measures in your hospital. And antibiotic prophylaxis and the usage usually has to be 1 hour, within 1 hour prior to the surgery. And then different antibiotics have different half-lives, and you need, if it's a longer procedure, you need to remind yourself and the anesthesiologist to work as a team to remind you that you have to read those and make sure that that patient is covered. There are key components that determine safety. Technology is one of them. You need to know, your residents have to know how to use certain instruments, from laser to staplers that are automatic or mechanic, but they have to play before instead of playing inside a patient's body. I think that is very important. Ergonomics is extremely important for your life, and for your life that is a marathon, your work that is a marathon every day, and not just a 100-meter sprint, you know. The environment is very important. Noise. If you like, sometimes you go to a room and you have this crazy rock. I love classic rock and all that, but when there's a lot of noise, you cannot communicate with people. People are talking about their lives, things that they did last weekend. That is not pertinent to that moment. And I think that has to be respected and should be an expectation from the surgeon, the nurses, and anesthesiologists, and everybody to know that, so you don't have to keep repeating that. The positioning, there are several papers, but not a lot of papers in our literature. We have to understand what are the positions that can cause rhabdomyolysis or perineal nerve damage, and so on. And the more laparoscopic robotics we do, we're learning more and more, like corneal edema from steep Trendelenburg that is more than 2 hours, and so on. So we have to understand that. But one part we cannot forget about surgeon and surgeons' ergonomics. Has demonstrated that, unfortunately, the female surgeons, they will have a higher incidence of pain and muscle skeletal issues due to the instrumentations that are not tailored to their hands, and sometimes this can cause some permanent to temporary damage. Again, non-technical skills from your leadership. You are the leader, and you should expect a great deal of respect from each member, and you should respect each member of your team. Introduce yourself. There's something called ADAT. You gotta do that as part of your routine. And if you have problems and conflicts and disruptive behavior, that has to be dealt in a very polite way, and later you can diffuse that problem acutely, and later try to understand what caused that problem. And there are several mechanisms like S-bar and others that we have to be really aware. Leadership is integral, it's pivotal to have a culture of patient safety. Do not blame people, because you're not perfect, and nobody is perfect. Music should not be a distraction, should be actually enjoyment. So make sure that you know the laser and fire safety, and always know that safety comes first. The impact of this ineffective communication is something predominant in our healthcare business, And we as leaders, we need to work daily to change that so people don't come and start really pushing for regulations from the top down. It has to go from the bottom up. Thank you so much.